When we think about leading edge, we often make reference to artificial intelligence. The problem with that is that organizations use that as kind of an easy button right now. We'll just skip over the basic foundational layer of analytics and jump all the way to artificial intelligence because it's being touted as the catch-all panacea of the things that we have wrong in our healthcare system. But, if you talk to people who actually know about these sorts of things, you need to do the basic foundational stuff first. If you build a mega mansion on a bed of sand, that house is not going to do you any good. You have to get that foundation right. And unfortunately, the foundation doesn't sell the house, but you have to have that as a prerequisite. And they want the $3,000 Toto toilet.
Right.
They don't want the sewer pipes that go into the house.
Welcome to Beyond the Blueprint, a podcast designed to empower healthcare professionals, enabling them to improve care delivery through integrated design and technology innovation. My name is Greg Malkery, and joining me is my co-host, Keith Washington. Whether you're redesigning a hospital, launching a new digital initiative, or just curious about the future of healthcare, then you're in the right place. Let's explore together what's possible when we go beyond the blueprint. Today, we're looking at the biggest problems within emergency departments, why they're hard to fix, and how AI could help improve patient care. To help us answer these questions, I'm joined by Dr. John Lee, a nationally renowned healthcare informatics expert and former CMIO at Allegheny Health. John, welcome to the show. This is actually your third episode with us. Before we dive in, can you tell the audience about yourself and how your experience connects to the emergency department?
Well, I'm practicing. And first of all, thank you for having me again. You can start calling me Alec. So I am a practicing emergency physician. I spend probably about a third of my professional life actually on the front lines taking care of patients in the ED. So it's a very intimate, personal and firsthand experience for me, but I also spend about 2/3 of my time doing IT work. And so that allows me a little bit of a picture underneath the hood of our healthcare system and understand why some of the things are dysfunctional and why some things work, and more along the lines of what doesn't actually work and why patients end up in the ED and why things don't work as well as they should.
Great. Thanks, John. Keith, do you have any opening remarks for today?
Well, yeah, thanks, Greg. So just those that are joining for the first time, Beyond the Blueprint brings together thought leaders to explore how innovative design can be used to manage complexity and enhance patient care. And the idea is that good design not only aligns organizations with their core mission, but also promotes collaboration. So our Beyond the Blueprint Health podcast, we hope to offer insights into navigating change and alignment of care teams to really focus on patient-centered care and really highlighting the importance of effective leadership in implementing systematic design. So that's what I want to just let everybody hear that. And back to you, Greg.
Great. Thanks, Keith. Now, before we dive into today's discussion, I want to recognize our valued sponsors who've made Beyond the Blueprint possible, Storage Systems and Simplify Medical. With their support, we're able to bring you insightful conversations around healthcare design and innovation. If you enjoyed today's show, I encourage you to subscribe so you never miss a future episode. Well, today I also want to share my inspiration for today's episode. It's always important to know the key influencers that go into Beyond the Blueprint, because we're constantly on the track to identify new and exciting episodes. I recently spent 10 hours in the emergency department at Stanford Health. It was a long day, but gave me an opportunity to see the staff in action. I watched how they work together, manage their tasks, and coordinate as a team. So even though I was there for a long time, 10 hours until 2 a.m. to be precise, with my Chipotle burrito in hand, I was actually impressed with what I saw. I had the opportunity to talk to the ED staff, which I thought was great. But when I shared my experiences with John, he was a bit underwhelmed. He goes, "You're confusing activity with efficiency." So as a result, this is what went into the generation of this episode on Beyond the Blueprint. So with that, why don't we start, John?
Absolutely.
John, EDs are known for being high pressure environments. What do you see as the most significant problems that EDs face today?
Well, I think the most significant problem that EDs face today is the same problem that everybody has in healthcare. And that's a lack of information and transparency and some of the systemic issues that Keith described that can help influence how things can work better. So in your case, Greg, just based on our conversation, your visit probably should have lasted an hour and a half in my estimation. But the things that affected your care were systemic issues that were external to your particular presenting problem, and even external to the department as you presented to it on that particular day. And so, whether it's throughput or making mistakes or just burnout, all of these things have all sorts of externalities that oftentimes are not necessarily identified in trying to manage some of these sorts of issues.
Can you share an example where systematic issues created bottlenecks or inefficiencies?
Well, I actually shared this. Do you know who Stacy Richter is?
No, should I?
You should. I would definitely recommend
tell us
her.
then.
I will plug her podcast, Relentless Healthcare Value. And so she actually had an episode. Her latest episode was about emergency departments, mainly about coding, but she had asked me my opinion about some of the issues that are occurring. And I cited one example that stood out in my mind, relatively recent example, where a patient came in with abdominal pain. She'd been having the abdominal pain for probably at least 2-3 months. She'd been trying to get into her primary care physician's office, and she couldn't. She was given an appointment for another month and a half downstream. And so she came in with the abdominal pain. The abdominal pain was getting worse. So I did basically a full workup, a workup that probably would have taken the course of several days or maybe a week or two as an outpatient, but it could have been done during that period of time a month earlier. And she could have completely avoided the emergency department altogether. And that's because of all these other issues that are occurring in the ambulatory space. And then you experienced, Greg, was a lot of backup probably from stuff that was going on the inpatient side of things, where patients aren't moving through the inpatient space fast enough so that we can't get the patients up to the inpatient floors. So all these things affect and negatively affect things that are going on in the emergency department. In the case of that patient that I saw in the emergency department with the abdominal pain, that it could have been addressed as an outpatient. Now multiply that was not an isolated incident. As I talk to emergency physicians around the country, this is something that's happening over and over and over again. So you multiply that, and the capacity of the emergency departments are relatively inelastic. So once you hit a certain threshold, all of a sudden the wait times and the wait times skyrocket and the throughput plummets. And that, in sort of a small nutshell, is what is the issue, I think, of what's going on in our emergency departments now.
I think you raise a very good point. Now, it's interesting when I was there, because I knew I was going to be there for a while. That's why I had my sandwich in hand, and I had my podcast.
Wait, don't ever do that when you go to the emergency room.
Don't do what?
Don't eat, because there are any number of things that we need an empty stomach for, and you could screw things up by eating something before you get in.
That's exactly why I asked the triage nurse if I could eat. Yeah, that was good. I got to know the entire ED staff, right? I got to talk to all of them. At 2 a.m, they want somebody to talk to. Now, what I found interesting as I was there is that they only had one question they were interested in. What is your pain level on 1 to 10? And I said, but you're not asking the right question. The right question is, are you in danger of losing your eyesight within the next couple hours? But they weren't interested in that, which I thought was kind of interesting. And that's the reason why I was actually in the ED. So I guess that's how they triage and know where to put you in queue. All right. That being said, challenges like overcrowding and lack of coordination are not new, yet they persist. What do you think why are these problems so difficult to solve?
Because they require strategic planning and resources, and those additional resources most often don't yield an immediate revenue. So, for instance, that patient that I saw in the emergency department, that patient, as inefficient as that was in terms of the balance sheet, that patient and that patient's experiences was a net gain for our healthcare system financially. Instead of getting a more efficiently deployed testing done as an outpatient, which would have probably cost probably a quarter or a third of the cost of coming into the emergency department. It expended a lot of resources, charged up her insurance substantially higher than she would have if she came in and had it addressed in a more ambulatory and regulated manner. But the healthcare system got more money out of it. And why should a healthcare system spend more money, say, in providing lower revenue ambulatory services when they can just squeeze more people into the emergency department? Now, that is actually being a little bit oversimplistic. There are other mechanisms and other metrics that people are starting to bring to bear to address some of these issues. But ultimately, it's a lot about dedicating resources to fixing some of the underlying systematic systems. And that sort of allocation of resources just doesn't make sense to a healthcare system that is typically running on 1 or 2% margins or even negative margins.
When you're in the ED, are you focused on cost or are you focused on care quality, right? Those are two different metrics, right? So what are you focused on? And is Epic, as is driving your workflow, is it guiding you toward healthcare utilization?
Well, that's a lot of questions. Number one, quality, certainly, yes. Throughput, absolutely. But oftentimes getting to those two things will negatively impact cost, or actually, in other words, increase cost. So for instance, a patient comes in with abdominal pain, and rather than getting the initial series of tests to see, hey, does the patient have certain lab test values that show that the patient may not need imaging studies, or that they may need a specific type of imaging study, we will do all the lab tests and order the imaging study with a rough estimation of what the patient may need, and do that all on the front end so that we can compress their workup into a shorter time frame. And we may guess wrong with that imaging study. They may get that imaging study and then have that result come back at the same time the labs come back, and we realize, whoa, maybe we should have ordered an ultrasound instead of a CAT scan. Well, now you're going off to get an ultrasound. So it's that sort of, we often talk about that you want good, you want cheap, you want fast. Choose two. That's how we've often considered how to balance some of the resources that we have in the emergency department.
Do you get real-time feedback on how you're doing? Is there some kind of metrics that's in front of you, knowing, or you're making the best decisions you can with all the patients you got, a 14-hour day,
And it very much is dependent on your training as an emergency physician and your experience. I know a lot of emergency physicians who, say, recently got sued, and so they will test out the wazoo and, increase resource utilization. And there's really no negative impact or incentive to do that other than some quarterly or annual review of you're ordering too many tests. But even then, it's more of a pride thing that you're practicing good medicine rather than a significant impact on the provider professionally or even financially.
John, what strategies or tools have you seen work effectively in addressing ED challenges? Now, you certainly have direct experience at Edward Health, but you're also a leading HIT consultant. So maybe you can talk to us about what is leading edge today in terms of addressing these challenges.
Leading edge is far lower than I would necessarily want. The places where I've seen things improve. Well, let me back up a little bit. When we think about leading edge, a lot of times right now we often make reference to artificial intelligence. The problem with that is that organizations that kind of use that as kind of an easy button right now haven't even availed themselves of the full breadth and quantity of simple level 1 descriptive analytics. They think that, well, we'll just skip over the basic foundational layer of analytics and jump all the way to artificial intelligence because it's being touted as the catch-all panacea of the things that we have wrong in our healthcare system. But, if you talk to people who actually know about these sorts of things, you need to do the basic foundational stuff first. You need to shore up your basic descriptive analytics and make sure that is working and a really well-oiled machine first. And then on top of that, hand in hand with that, you have good data governance so that the data that you know that you have in your system feeds into the analytics and you can trust what the analytics tells you And then once you have that in place, then you can go up the evolutionary stages and get to things that are more advanced, like artificial intelligence.
Is this all part of Epic or these third-party tools? Are we using other types of things like ChatGPT in the ED? Or things like MedPearl, which we learned about a few episodes ago with Dr. Jessica Schleicher at Providence Health?
All of the above. And one of the things that's happening with Epic is that they're starting to bring in these third parties and essentially embed the third-party platforms into their systems. So the actual engine, the power behind the insights that are being surfaced up for the end users and even the patients is being supported by the third parties, but actually it looks like it's an integrated part of Epic.
Would you say is the use of these types of AI tools, would you say it's a high priority for investment? Or would you say it's emerging and there's still a lot of experimentation being done?
Again, all of the above. I think it's a high priority, and there's certainly a lot of hype behind it, and I think a lot of expenditures. But I think that a lot of healthcare organizations that do invest in AI type solutions will be sorely disappointed at the end results if they haven't done that underlying foundational level and gotten their data governance in order and gotten a certain level of data literacy within a critical mass of the people who decide things at the managerial, director, and executive levels, so that they know which tools are best used for certain circumstances. And on top of that, know how to create the underlying data that can produce the content that they want.
Well, this kind of reminds me of Field of Dreams. If you build it, will it come? So my question to you is, what role does change management play in making sure that new tools or workflows are successfully adopted within the ED?
There is a certain element of, if you build it, they will come. The caveat the addendum I would make to that is, if you build it, they will come, or it will work, but you may have to wait a while if you do it right. But then once you build it and you get that good foundation in place and you use it over a few different iterations and it infuses into the culture of the organization, all of a sudden you will start getting kind of a hockey stick increase in utility that often comes with the classic diffusion of innovation.
Well, I know offline we've talked a lot about AI and augmented intelligence. In your estimation, what does the future hold for augmented intelligence in healthcare today and maybe over the next 12 to 18 months? You can just give us an honest assessment, and especially as it might relate to reshaping the ED.
Well, I think the metaphor that I think might resonate with people is how the self-driving technology has the different bits and pieces have infused into how we drive, even without an advanced self-driving car. So my personal favorite technology addition to my driving experience is, before we would have cruise control, set the speedometer to 70 miles per hour and you keep going. But then once you end up getting traffic, you have to turn that off. Whereas now you have the speed assisted self-drive cruise control, and that has become relatively ubiquitous. Now you take that same sort of analogy and you start inserting that same sort of mindset into what we do in healthcare, where you have these very, very moonshot-ish type of endeavors where you walk into the patient's room, you have a patient talk to you, and then everything's done by the computer and everything's smart and you're not going to make any mistakes. And it looks at all the outside records and realizes that, hey, the patient already had a mammogram and you don't have to order the mammogram, but all the other care gaps are automatically ordered without you even mentioning it. So that's the sort of autopilot that that's essentially like a self-driving car. But what's happening is that the elements that are being developed that get to that moonshot are starting to be infused on an ad hoc fashion. And they're starting to show up in everybody's workflows. And gradually what we're going to get is, we may not necessarily get to that fully automated experience, but it will be substantially better at it, and get to a point where you'll start adding all of these sorts of technologies in, and it will be relatively ubiquitous. So you'll have kind of an 80-20 principle where you have 20% of the technology is massively impacting 80% of the workflows. you don't have to get from 20 to 90 or even 100%. If you just get to 20%, you've already massively improved the workflows and the outcomes that we deliver.
I actually totally agree with you. From talking with Jessica about MedPearl, it gives you the ability in real time to guide you through the clinical process. So no matter where you are, whether you're in downtown Seattle or on an Indian reservation, you can perform at the top of your licensure in accordance with standards for the health systems or on a national guideline basis. And you also no longer have to read these 50-page PDFs, which actually helps your throughput.
So I would make a pitch so I agree with that. But if you take it to the next, the ultimate step is that you don't even have to use MedPearl. It's just infused into your workflow and the content just shows up based on the encounter that you have with the patient. And I would say that that's actually where Epic is going with their Cosmos platform.
Oh, interesting. How far out do you think we are before we see this as a standard of care, something that's being utilized by majority of docs, ED docs, actually all disciplines for that matter?
It's so hard to say because my initial inclination is that we're at least 5 years away. But I remember I had a conversation with somebody just recently about how I think it was 3 years ago that Nuanced Stacks at HIMSS had their ambient documentation platform, and they were the only ones that had it. And their solution was pretty good, but it was not quite up to being ready for prime time. 2 years later, ambient documentation was everywhere. There's at least a half dozen vendors that had really usable solutions, and almost getting to the point where it's a commodity. Not quite. There's some significant differences between the vendors, but that's an example of something that moved really, really fast. And I just got to think that it's a complete wild card at this point to when technologies like MedPearl being completely embedded into workflows or Cosmos generated insights, what they call best care for my patients, or just show up in provider workflows without them even asking for it.
Last question before I hand it off to Keith. Are there any other emerging technologies or trends that you're excited about as it relates to the future of the ED? And feel free to reference certain established organizations in the country that may be pushing the envelope.
Well, I have to say that the focus on these sorts of high-profile initiatives is a little bit misguided. It's a little bit straying off and chasing shiny objects. The place that I think that will help us more than anything else is, again, going back to the basics, doing that basic data governance. If you build a mega mansion that's a beautiful house, but it's on a bed of sand, that house is not going to do you any good. You have to get that foundation right. And unfortunately, the foundation doesn't sell the house, but you have to have that as a prerequisite. And we have to do that with our data and how that then feeds into some of these 21st century data science and artificial intelligence tools.
If you were to get together with some of your buddies at HIMSS or HLTH, focused on the ED, is there a lot of consensus on the issues that are in front of the ED today and how we might want to solve them? Or is it across the board in terms of possibilities?
All over the place. And I think a lot of it depends on who you talk to.
Yeah. Well, thank God we got you as a thought leader here today. So with that, I want to hand it off to Keith. I know Keith's got a bunch of questions he wants to ask you.
So thanks, John, for that perspective. Very helpful. So wanted to maybe double click on the topic you mentioned about strategic planning. So if you put on your consulting services hat, when you go in and engage with an organization, how do you approach that topic? How do you get them to embrace more of a strategic planning process? Or what do you think that looks like when it's well executed?
Well, I think one of the things that you want to highlight that I've discovered recently is that a lot of organizations don't know that they have the pain that they're experiencing. So as an example, I was working with a biomedical device vendor recently, and they were trying to get patient populations in for studies so that they could get their biomedical device approved by the FDA. And the process by which they brought me in just to help with some of the data aggregation. But then I looked at their processes and it was really pretty antiquated. But this is just the way that they've been doing it for the past years or even decades. And so they did not know that that the process was as painful as it was, at least relative to what it could be. So one of the things that I would say is that oftentimes you don't know where your pain is, but if somebody can show you where your pain is and what some of the opportunities are, then there is opportunity there. And there's plenty of opportunity, because the biggest problem that we have in healthcare right now, or actually, I think our economy writ large, but especially within healthcare, is that we don't have information transparency. People don't know, a person waiting for a hip fracture doesn't know how much to budget for the patient who comes into the emergency department, and I send them to a clinic, doesn't know if that clinic is actually covered by their insurance. If I order a test in an ambulatory setting, I don't know for sure how long it's going to take to go through that prior auth procedure. And quite frankly, I probably don't know what are all the different data points that I need to submit for the prior auth. There's a lot of friction points.
Yeah, that's those are always really challenging dimensions. So, because we're talking about like leadership from inside the health system point of view, particularly say an emergency department, but then let's say as part of the community you serve, trying to get all that complexity, that really adds another layer. It's the way we like to talk about it is sometimes the care team coordination on the operations side, delivering patient care. But then from the patient side, I think what you're mentioning is the health system navigation and all its complexity and how to manage all these different dimensions, just extremely complex. But I guess that's where, what you were talking about in terms of the transparency and the data governance and sort of laying that foundation.
Hold on a second.
Yeah, go ahead.
Sorry about that. Let's
no worries.
ask the question again.
Yeah. So it was talking about how you were highlighting the importance of transparency and then building that foundation, that solid foundation that you can then build on. So, instead of building on sand, building on rock or some really sturdy foundation. So I guess in the context of leading an organization and leading it well, I guess how would you think about that maybe in terms of what are the incentives for the team to want to do that better? What are sort of when you're hiring or when you're doing employee evaluations or when you're like kind of looking at the organization, what do you think, what have you seen maybe that's been effective in helping drive that move towards transparency, building that foundation and maybe making it more of a priority?
That is the places where I think we have the greatest opportunity are also the places where it's difficult to make a pitch to dedicate a lot of resources. So I'll harp on it again. Data governance, data literacy, and actually creating a level of what I call semantic data abstraction so that you can take the little bits of what we call atomic data, assemble them together and come up with something meaningful so that those data points are then accessible and understandable by everybody across the organization. And what ends up, I think if you can do that, then all the other stuff kind of falls into place.
Right.
Because then you can start answering questions much more nimbly than what is, generally speaking, what the current status quo, where every single question that comes up has to be reassembled from the atomic data and come up with some insight and visualization, and you have to hash and rehash and do that all over again. And I would actually say that is, from my perspective, the biggest opportunity for artificial intelligence, because what I just described is tailor-made for artificial intelligence. But what ends up happening is that healthcare organizations don't necessarily want that, because that's kind of boring and mundane.
Right.
To use the house on foundation metaphor, they want the $3,000 Toto toilet.
Right.
They don't want the sewer pipes that go into the house.
Yeah, no, that makes total sense. I appreciate that analogy and that, kind of chasing the shiny object versus just building a solid foundation, becoming the kind of organization that you want to become really takes all that work. That's very difficult, as you said. No, I think that's a really good point of view. So I guess, we've got HIMSS coming up. John, what are you going to be looking for at HIMSS? What gets you excited if you're going, and what are you looking forward to?
Honestly, personally, it's mainly about networking and sharing ideas. After all these years, I've actually become a little bit, the word maybe not necessarily disillusioned, but I try to avoid the shiny objects because I've been pulled in to that. There are a lot of shiny objects, and what I want to do is do my best to try to connect and work with people to get good data governance, good data literacy, and be able to create the underlying foundation. Because once we actually build that, then everything will kind of fall into place.
Yeah, well, I think that's part of why we have these conversations on our podcast here is it allows you to express that frustration and then maybe engage in your networking to say, hey, these are things that, we can have this great vision for this future state, but, if we don't lay the foundation and do the work, like it just doesn't happen by itself, right? So I think that's a great takeaway and much appreciated in your perspectives. Certainly looking forward to seeing you at HIMSS, and back to you, Greg.
Great. Thank you. So, John, it seems like we're perhaps in the trough of disillusionment. I think that was part of the Gartner hype cycle, right? Maybe that's a good thing, right? Because as part of being in the trough of disillusionment, maybe there could be some new emerging trends that we could be following next. And I'm hoping to see that at HIMSS. Then again, that could be rose-colored glasses.
Well, I would say that there is a little bit of caveat to that. I do think that there's some really interesting and impactful technologies that will come about. I'm really excited about ambient. I think it has truly hit the prime time. I do think that the way it's being used right now only leverages a tiny part of its potential, long-term potential. There's like data and chart summarizations, I think, are going to be in that next bucket of things that are going to be highly useful relatively soon. And of course, I'm always been a fan of Epic and the things that they're doing. I think that Cosmos is going to make a big impact relatively soon.
John, before we conclude, would you like to give the healthcare leaders who are part of our audience some guidance on how to optimize their EDs to help increase efficiency, improve care, or help reduce costs? What pearls of wisdom would you like to leave them with?
Well, the pearl of wisdom I would use was referenced by Stacey Richter on her podcast. She was talking about a balloon and how all the different other pieces of the healthcare system are being squeezed. And because they're being squeezed, the balloon squeezes out in the one place where it can't squeeze out, in the ER. And so if you want to address some of the ER throughput and inefficiency issues, unsqueeze the balloon. Work on ways to get patients through the inpatient units faster. Work on ways to get patients into the clinics for relatively acute or subacute problems. And if you can do that, you will actually decrease your ED problems.
Great. Hey, John, for audience members who want to reach out to you for expertise in healthcare informatics, how can they get hold of you?
They can contact me on LinkedIn. You can look me up, although there's a lot of John Lees out there. You can connect with me and ping me on my website, hitpeakadvisors.com, or you can email me directly at johnlee@hitpeakadvisors.com.
John, thank you very much. Pete, do you have any final thoughts on today's session?
I want to thank you, John, for sharing your expertise. And I think shedding a light on this role that the emergency department can play in transformational leadership and around the insights by really focusing on the foundation and dealing with the complexity, both upstream and downstream in the overall process across the whole health system is really valuable. And then how to use technology to help navigate that dynamic landscape is really a powerful way to think about it. So much appreciated. And I just want to thank our audience too for joining us in this journey on Beyond the Blueprint. We hope this discussion really gave you some ideas and inspired you to how to leverage technology and focus on building that foundation that John talked about. And just hopefully, John, we look forward maybe to having you back in a future episode and continuing the conversation on what it's going to take to get us from here to there.
Awesome. Thank you for having me.
Great.
Right.
Thank you.
Thanks.
Thank you for listening to Beyond the Blueprint. Together, we're exploring how thoughtful design can simplify complexity, enhance patient care, and create meaningful change. If you found value in today's episode, make sure to subscribe and leave a review in order to help us continue the conversation. Let's reimagine healthcare together on Beyond the Blueprint.